Okay.
Bismillahirrahmanirrahim. Assalamu alaikum. Respected audience, today our guest of speaker is Dr. Enrico Borelli. Dr. Enrico Borelli holds the position of Associate Professor of Ophthalmology and serves as the head of Medical Retina Unit with the Department of Ophthalmology at the University of Turin in Italy. Professor Enrico Borelli graduated from Vita Salute San Raffaele University, Milan in 2013. He completed his residency in ophthalmology at Gabriele Annunzio University, Italy, and his clinical research fellowship at the University UCLA from the Doni Eye Institute in medical retina and clinical imaging. He also successfully completed PhD at Vita Salute San Raffaele University in Milan, Italy, 2023. Professor Enrico also has got a great interest in research work. He has also got 200 research papers in which he authored and co-authored. Additionally, his studies identified imaging biomarkers that may guide clinicians in the management of patients with macular disorders. His work has been recognized with several international awards, including the Ophthalmologica Euroretina Award and the Rosario Brancato Retina Award. His research has been supported through the grants from Global Ophthalmology Award Program and Euroretina Retinal Medical Clinical Research Grant Scheme. He holds many patents related to his specialist field. Today, we have requested and invited Professor Enrico Borelli to present his talk about biomarkers in OCT biomarkers in diabetic retinopathy, diagnosis, and its prognosis. So without further delay, I request Professor Enrico Borelli to present his talk. Yes, Dr. Enrico, please.
Thank you. Thanks for the opportunity of speaking about biomarkers in diabetic retinopathy. I will share my presentation. We really need to see patients with diabetic retinopathy and diabetic macular edema using structural CT and also OCTA, as these two imaging modalities have significantly improved our ability to understand and also to predict the outcome over time. So I've divided my presentation into these points, and I will start with the clinical case. This is a patient with diabetic retinopathy complaining of a reduced visual acuity in the right eye associated with the metamorphopsia. We did perform structural OCT showing the presence of diabetic macular edema associated with the neuroretinal detachment. You may appreciate on the color code thickness map that there is a large region affected by diabetic macular edema, and also the thickness map may show you the amount of the thickness in this patient affected by diabetic macular edema. This patient was treated with anti-VEGF injections, and after treatment there was an improvement in the amount of intraretinal subretinal fluid. It was a complete resolution of the intraretinal subretinal fluid. Also, the color code thickness map showed an improvement in diabetic macular edema, and also the numbers associated with the fluid in this patient were reduced. So these patients had a complete resolution of the exudation associated with diabetic macular edema. However, there was no an improvement in visual acuity. So we need to use different biomarkers, and not only the presence and the amount of diabetic macular edema, to follow up our patients with diabetic retinopathy, and in particular those patients with diabetic macular edema. One of the most important aspects when we investigate patients with diabetic macular edema is the DME pattern. There are different patterns, including a diffuse thickening, a cystoid macular edema, or another pattern is the presence of subfoveal neuroretinal detachment. And we did perform a study a few years ago showing that the presence of a cystoid macular edema is associated with an increased neurodegeneration of the inner retina, while a subfoveal neuroretinal detachment is associated with a greater neurodegeneration of the outer retina. So those patients with diabetic retinopathy, and in particular those patients with DME, are affected by neurodegeneration over time, and the neurodegeneration is associated with the type of DME pattern these patients are affected. And we did speculate that the presence of large cavities may cause an irreversible damage to the cells located in the inner retina, while an accumulation of subretinal fluid may cause a mechanical damage to photoreceptors. Another important biomarker is the presence of intraretinal hyperreflective foci. Hyperreflective foci may be associated with different lesions, including hard exudates, or hemorrhage, or microaneurysm, or small capillaries. And there are some hyperreflective foci that appear to be associated with activated microglial cells. So there are some hyperreflective foci which seem to be associated with an increased inflammation in patients with diabetic macular edema. And there is this very nice study on a mouse model of diabetic retinopathy showing that those hyperreflective foci seen on structural OCT are actually associated with inflammation within the retina as suggested by histology. So we do have some hyperreflective foci in patients with diabetic retinopathy and in patients with diabetic macular edema, and these hyperreflective foci seems to be associated with an increased inflammation. When we see our patients with diabetic macular edema or our patients with diabetic retinopathy, it is always important to investigate the presence of structural damage. One of the most important biomarkers is the disorganization of the retinal inner layers, which is an OCT sign associated with the absence of any demarcation between the ganglion cell layer and the inner plexiform layer. And this OCT sign seems to be associated with a disorganization or a destruction of the inner retinal cells. And this OCT sign is also associated with a worse outcome in these patients. There is another important OCT sign, OCT biomarker, with a worse outcome. And when we have a patient with DME, we may want to look at the ELM or the ellipsoid zone layers, as a disruption of these two layers in the foveal region seems to be associated with a worse outcome in our patients. There is not only space for structural OCT, there is also space for OCT angiography, and we may want to use OCT angiography to investigate the presence of macular ischemia. Diabetic macular ischemia is one of the most important biomarkers associated with a worse outcome in patients with diabetic retinopathy. Diabetic macular ischemia may be due to the presence of capillary dropout and closing of the capillaries or arteries in patients with diabetic retinopathy. And we may want to investigate and also quantify macular ischemia using fluorescein angiography. However, it is easier to investigate and to quantify this ischemia using OCTA. Using OCTA, we may also quantify macular ischemia at the superficial capillary plexus level or at the deep vascular complex level. And this quantification is really associated with a worse outcome in our patients with diabetic retinopathy. So if you have a patient with diabetic retinopathy with or without diabetic macular edema, you may want to quantify the macular ischemia, as this may explain the reduced visual acuity in these patients. And another important aspect using OCTA is that the parafoveal perfusion density investigated using OCTA is an independent predictor for visual improvement after treatment with anti-VEGF in patients with diabetic macular edema. Finally, macular ischemia is also important as this is associated with the progression of diabetic retinopathy over time. So those patients with the lower macular perfusion may be characterized by a higher risk of developing proliferative diabetic retinopathy over time. Finally, using OCTA, there is also the presence of a false flow, which is named suspended scattering particles in motion. So when we look at the OCTA images, the presence of flow within the intraretinal fluid is only associated with the extravascular OCTA signal because of the presence of particles within this fluid. And this OCT sign seems to be also associated with a worse outcome in patients with diabetic retinopathy and diabetic macular edema. So in conclusion, we may want to use OCT, structural OCT or OCTA to identify biomarkers associated with a worse outcome in patients with diabetic retinopathy. We may want to use both OCT and OCTA. And however, OCT and OCTA must be used within a multimodal imaging approach, including also fluorescein angiography and fundus photography. Thanks for your attention. And if you have any question, any comment, these are my email addresses. So thank you so much for your kind attention.
Prof. Enrico, thank you very much for your presentation. I just want to ask a few questions. Prof, how do you use hyperreflective foci in your clinical practice when treating the patients with diabetic retinopathy?
So hyperreflective foci, as I mentioned in my presentation, may be associated with an increased inflammation in patients with DME. So these biomarkers may be used to guide our treatment. We may, in the presence of hyperreflective foci and in the presence of a large amount of of hyperreflective foci, we may want to use not only anti-VEGF injections, but also steroids as a treatment to resolve our DME. So for sure, hyperreflective foci may be used to guide our treatment.
Okay. Prof, how do you use this, and when you go for nowadays, both structural OCT and OCTA angiography, both are being used. How do you prioritize in the treatment of the diabetic retinopathy?
So that's a great question. Thank you. I usually perform both structural OCT and OCTA at baseline with also fundus photography and fluorescein angiography sometimes as well. When I start treating patients for diabetic macular edema, usually I treat these patients with a treatment and extend regimen. So I usually perform also only structural OCT over time to see if the treatment is effective or not, and also to guide my treatment over time. But for sure, OCT angiography is important before starting your treatment.
Okay. Nowadays, diabetic retinopathy is one of the leading cause of blindness or preventable blindness all over the world. And our videos being seen by general ophthalmologists and subspecialists also. So if we have to say the most important biomarker for poor outcome in diabetic macular edema, which will be the one you will name it, Prof?
So thanks for your question. It is difficult to say that there is one biomarker which is important than another. Probably one of the most important is the reflectivity of the outer retinal layers, especially the reflectivity, the disorganization or the disruption of the ELM is something important when you want to predict the outcome in your patient, and also if you want to understand, sorry, if there is extraocular damage associated with a reduced visual acuity.
Right. Prof, do you still use CST in your clinical practice?
I do use CST, but I prefer to scroll all the OCT images in order to see if there is any intraretinal fluid spot or any sign of subretinal fluid, and also to detect and to quantify biomarkers.
Prof, nowadays it is non-invasive to do OCT angiography, and more people easy to do it are going towards this OCT angiography. How do you see the use of the conventional we used to do fluorescein angiography? How do you see the use of both these modalities in the treatment of diabetic retinopathy?
Thanks for the question. Fluorescein angiography is still very important, as we do have wide field, ultra wide field fluorescein angiography, the ability to perform ultra wide field fluorescein angiography, which is something we cannot really do using OCT angiography. So if we want to really investigate the periphery in our patients, we may want to perform a fluorescein angiography, and fluorescein angiography is still important when we want to understand if there is any leakage. So fluorescein angiography is still important in our clinical practice, but OCTA has reduced the use of fluorescein angiography. We need to use both of them.
Prof. Enrico, thank you very much. I know you are extremely busy with your clinical teaching and administrative responsibilities, but you still accepted our invitation. And I want to thank you on behalf of my channel and on the behalf of my audience. Your talk will be very beneficial to our respected audience in their clinical practice. I want to thank you, and we are looking forward to more presentations like this in future also. Thank you, Professor Enrico.
Thank you. Thanks for the opportunity.